All right, just since the recording started, this is the June 5th, 2025 Evidence-Based Guidelines Subcommittee meeting. And Chair Linnea Lindsay has called the meeting to order. I will call the roll. I'm Jason Gingrich, Director of HERC. Mimi McDonald, I believe she's here.
Mimi, are you here?
No,
I
she'll
don't
be
see you.
late.
Okay.
Mark Buckholz.
Hey, I'm here, but the screen looks different. I can't see the video and I can't mute myself. Am I a panelist?
You are a panelist. We don't see you. We just see, your name, but no.
Right. Why is that? I want.
You might want to drop and rejoin, and we'll
Okay.
try promoting you again, I guess.
Okay.
But while he does that, we will call the others. Deb Esposito,
Here.
Devin Consagra is absent.
Oh,
Abby Khan is going to be absent. Larry Lyon,
he's waving.
Oh,
Larry, can you say something? Just say he present.
yeah. Can you hear me okay?
Yes.
yeah,
Okay. All right.
and Kat Livingston
Present.
and Leslie Sutton. Leslie, are you able to unmute? I see her name there, but maybe she's having some difficulties. And we'll see if Mark is able to come back off mute.
He should be rejoining us momentarily. I just promoted him again.
Yay, I'm re-promoted. I feel so promoted.
Yay. And then Leslie, can you just say present now that we see you?
Leslie might be having some trouble with her mute button, so I think we'll go ahead. Um,
Is this better? I have a new webcam.
yes,
Yes.
now we can hear you.
Because I have a new webcam. I'm so sorry for the drama, but it sounds like everything's working. Thanks.
So the worst drama that happens today, it's a good day. Okay, Linnea, back to you.
The next item is we need to look at the minutes from our last meeting. So I think
Those are the minutes from the April meeting. Does anyone have any questions, concerns, requests for any changes? If not, we need to approve them.
The April minutes. Or was that May? Excuse me.
It's April 10th.
April 10th.
I vote to approve.
You have to second the motion first.
Yeah, we need a second. Is there a second, Mark?
Second.
All right, I will call the roll then. Let's see, Mark,
Approve.
Deb,
If you're talking,
Sorry.
Deb, we can't
Approve.
hear you. Oh, okay.
Approve.
at Larry,
Approve.
Kat,
Approve.
Leslie,
I need to abstain. I wasn't at the meeting. Thank you.
and Linnea.
approved.
Right. Ready for the orientation presentation? Yeah. So this is the Evidence-Based Guidelines Subcommittee. Next slide. Next slide. So as a reminder, OHA has set a goal to eliminate health inequities in Oregon by 2030. Our purpose here today, our little part of that, is to develop reports to guide coverage for the Oregon Health Plan and other plans. We're also approving some recommendations today that will go to the commission related to the benefit update project. These decisions will affect over 1 million OHP members as well as their families, caregivers, and providers. There will not be any decisions about individual care made today. This subcommittee's normal work is to develop coverage guidances and multi-sector interventions to guide coverage. However, today it is all about that benefit update project and these these decisions won't be in effect until 2027. The main considerations, as always, are what outcomes are important to patients, assessment of the harms and benefits balance, the patient values and preferences, stewardship of public resources, and just the nature of our healthcare delivery system here in Oregon. And Daphne is gone today, so please, instead of Daphne, please use the Q&A, or sorry, use the chat to message me or Jessica when you're stepping away or coming back, or if there are logistical issues. And we're going to vote verbally today, just as we did a moment ago. I don't believe we have anyone registered to testify today. And if you have something to say and you didn't register to testify, you can use the Q&A feature, and we'll respond to those as we're able during the meeting or follow up afterwards. Anything put in the chat or question and answer is part of the public record. Meeting is recorded and will be posted publicly online. So it'll be there for posterity. And just as a reminder, we try to keep the discussion verbal. So if you have something to say, raise your hand or just speak up if you remember. And if you have something you don't want to put in the chat or the Q&A, that's the email address, and we will respond to that after the meeting. Okay, next we need our conflict of interest declaration. As always, give members a chance to declare any conflicts of interest or personal interest with respect to any of the topics on today's agenda. All right, hearing none, I think we can go on to staff update. Legislature is still in session. There are a number of bills affecting our work, several bills to broaden coverage of services broader than what the HERC has approved. Those include biomarker testing, continuous glucose monitoring, coronary artery calcium scoring. All of those are in Joint Ways and Means with a fiscal attached. And depending on funding, may or may not be approved. There is also a bill related to the Benefit Updates Project. It's called the Task Force Bill, and it is also in Ways and Means pending fiscal. And so I don't know whether any of those will move given the budgetary situation, but that is the current status. Also wanted to update you all, we have some recruitments open. Thanks to those of you HERC members who suggested people at the last HERC meeting. We've got some great applicants we're going to be interviewing. We have a consumer rep role, behavioral health role, as Dr. Lindsay will be reaching her term limit at the end of the year. Leslie Sutton will be reaching her limit. I guess this is past her limit, but has agreed to serve until replaced. But we have some consumer rep applicants that we're going to be interviewing. And then pharmacist role. And we also have an applicant for that. So we'll be interviewing them and submitting those to the governor for consideration. We also have some great applicants to consider for subcommittee only roles. So excited about that. Recruitment is still technically open. If you know anybody who would be good, feel free to have them, still use our process to apply. But just wanted to give you an update on the status of that. Finally, our listening sessions that we've been having. We canceled one, and then the other one because we were able to address the issue by email. We just didn't need a listening session. So we've still been getting topics through those. We just haven't been actually holding the listening session. So I think the PR is working. And welcome. I see Devin Consagra has joined. So we did have the two topics come in, insomnia and hypersomnia, that will be reviewed by the VBBS next week. And finally, I just wanted to review the role of our colleagues at the Center for Evidence-Based Policy, Val King, Marcus Bachhuber, Shauna Durbin. I think those are the only ones I see today. They are consultants. They are contractors from OHSU. For us, they prepare independent research, including the coverage guidances that you all review in this group. They are not state employees. We Part of the reason is just to have an independent opinion outside the state um, government OHA bureaucracy. So we're glad to have them. They do great work, but it is a slightly different role. So just want to make sure everybody's clear about that. Any questions about any of that on the staff report?
And in regards to the listening session, I just wanted to add, if you have folks that you run across that you think would have an item that would be great for a listening session, please, we're planning on having them going forward. As Jason mentioned, the last couple either we were able to take care of in other ways. So, but we definitely are looking for people to have come and talk.
Okay, thank you. And I think that is all for the staff report. We can go on to the benefit update project.
Great. So as you're all aware, we have kind of hijacked your subcommittee to work with us on our benefit updates project. Just as a reminder, CMS has requested that we move away from the prioritized list as a way of framing managing our benefit package. And we are working on a new way of expressing the intent, the evidence reviews, and the all the thoughts and everything that the HERC has been doing. We're coming up with a product, and I'm not quite sure if we've landed on a name, but it will be it will have it will be kind of like a prioritized list that doesn't have a funding line. And our main job right now is we are looking at all of the lines below the current funding line, and everything at a minimum will get an office visit for evaluation, appropriate um, diagnostic testing, medications if they're appropriate, and DME if it's appropriate and meets the DME rules. That is very similar to today. So we're kind of calling that our baseline. So if that's all a condition needs, then that goes into what we're calling evaluation and medical management. They'll get all of those services. What we're really trying to piece out now is which procedures need to be done for which diagnoses that are currently non-funded. And this would be something that may end up being an added coverage. Hopefully that's not all that confusing to you all. So we have two main areas that we're going to be discussing today. The first one is women's health, gynecology type topics. The second is dermatology or skin conditions. You all saw the gynecology topics, I believe it may have been 2 meetings ago, and approved the staff recommendations essentially as presented. This went to HERC at their March meeting, and the members of HERC had multiple questions, concerns, and requests for further evidence review. So this piece that's coming back to you is trying to address the questions that were raised, as well as 2 additional evidence reviews for the effectiveness of hysterectomy for chronic pelvic pain and for dysmenorrhea, because of the request to see evidence about the effectiveness of those treatments. And then there was a lot of just questions. What is this procedure? What is it used for? What is this diagnosis, et cetera? So the first item that you should have, which is on the screen in front of you, is the general gynecology. Just as a reminder, the questions that HERC had, they wanted those evidence reviews for dysmenorrhea and chronic pelvic pain, which we'll see in a few minutes. They also wanted to know, when does a Bartholin gland cyst need a procedure? And when does a vulvar polyp or cyst need to be removed? That was one question. What treatments should be covered for post-endometrial ablation syndrome, and essentially what is that syndrome? Looking at hysteroplasty and hysteroscopy for uterine septums, and when is that indicated? And then looking at some subdiagnoses of a very vague diagnosis code. So the first one was Bartholin.
Ariel, just mention that Mimi is not here, but will be coming up 4. So if we need to save any questions for her, we can do that.
Excellent. Great. So the first question is, when do you treat a Bartholin gland cyst? We currently cover them when they are abscessed, but not when it's simply a cyst. Sort of expert opinion, there was a review that's good 15, 17 years old, and that essentially symptomatic cysts should be treated essentially the same way that we would do an abscess. So incision and drainage, fistulization or marsupialization. And then there was a RCT published in 2017 looking at ward catheters, which is a type of a tube that kind of goes into that area to drain the cyst, versus marsupialization, which is more of a surgery to kind of open the cyst. And they found they were both equally effective. The ward catheter usually is something that can be done in the office and is lower cost and typically faster. So that has the positives there. So essentially, just in summary, Bartholin gland cysts, the standard of care is that they are treated when they're symptomatic, meaning large, painful, or infected, which we currently treat. Post-endometrial ablation syndrome is it's a condition that was first reported in 1993. So it's a very specific sequence of events. A patient has a tubal ligation and then later on undergoes endometrial ablation, usually for menstrual bleeding disorders. In a very small group of that has had first the tubal ligation and then they have the ablation, they end up having retrograde menstruation into the tubes and they have tubal dilation and pain. The treatment is salpingectomy or hysterectomy. So the recommendation of our experts to pair hysterectomy with this syndrome is appropriate according to current standard of care. For vulvar dysplasia, which is also known as vulvar intraepithelial neoplasia, the current ACOG recommendation is that you should have high-grade squamous epithelial lesions it should be treated with wide local excision, laser ablation, or topical imiquimod, which is a sort of a topical chemo. And then there is a difference that has sort of become more evident with HPV-independent VIN versus HPV related, and that essentially you need to do a wider local excision. So vulvar dysplasia, the answer to that, what do you need? You need, especially if it's high grade or HPV independent, it needs to be excised. In general, it needs to be removed. Uterine septums, these are membranes, or so in fetal life, the uterus it has two structures that fuse. Sometimes that middle of the fused entity isn't resorbed, and so there's a piece of tissue that running down the middle of the uterus. The current American Society for Reproductive Medicine guideline recommends that you excise the septum if there is recurrent miscarriage, and patients should be counseled that if they have a septum, they may want to consider incision before pregnancy to reduce malpresentation and cesarean section rates, although that's expert opinion, not based on any evidence. And then there's insufficient evidence to recommend hysteroscopic resection of the septum in patients who are not considering resection. And then I got some expert input on uterine septums from Dr. Elizabeth Rubin at OHSU. So essentially, she recommends resection for recurrent pregnancy loss or adverse pregnancy outcomes like preterm birth, someone who is trying to conceive after shared decision making, if it obstructs the outflow tract of the uterus so that there's bleeding, retained blood, etc. And that can happen if there is an asymmetric one or a transverse septum, and then infertility and chronic pelvic pain. So our staff summary is essentially symptomatic cysts, Bartholin cysts should be treated. Post-endometrial ablation syndrome, you should pair with hysterectomy and salpingectomy. Vulvar polyps should be removed when they are large. However, many of these are small and similar to skin tags on other parts of the body. So the staff recommendation is actually to place these on evaluation of medical management, and very large polyps can be treated as an exception, or if there's a diagnostic question, a diagnostic excision can be done.
I have a question about that.
Of course, yeah.
So vulvar polyps, even if they are small, they may be potentially precancerous. So I'm just wondering, to catch something early may be is very appropriate. At the same time, the problem is it precancerous or not? And I see that we would be treating them similar to skin tags. I'm just wondering if that's the best way to do it. And I would love to know some more expert opinion on this.
I think the precancerous is pretty rare. If other folks are concerned, we could consider adding them to a group that has excision. I think when we have talked about these in the past, the concern has been that a lot of the removals are more either cosmetic or like patient preference. Does anyone else have comments on that? Does anyone else feel like we should do resections? Are you comfortable with having those be sort of an exception? Do you want to wait till Mimi's here and we can ask her?
Yeah, I'd like to get some. This is an area that I'm not familiar with, but it just raises a question in my mind because of because some of them can be precancerous. I'd love to get someone's opinion who actually is an expert in this area.
Okay. So what we can do is we can hold that one specific decision until Mimi is here, and then we can kind of vote on anything else.
Whatever it's worth, I looked it up on open evidence, and it says they're generally not precancerous, but agree with asking Mimi.
Okay. And then for vulvar dysplasia, we actually have higher grade vulvar dysplasias in what's now currently line 433 will become code group 433. And actually what was in this for discussion ended up being the unspecified code. So I think that's going to be a simple fix. We'll just add that to code group 433. I was asked to come up with the subdiagnoses for ICD-10 N9489, which is other specified conditions. There's a very large mixed group. The only thing of any concern is hydrocele of the canal of Nuck. This is an extremely rare condition that can lead to a hernia and requires management. And if that is what's actually going on, that would be a pretty easy exception, I believe, to make. One of the things I was asked to find about was trachaloropy, which is known as plastic cervical repair. This was kind of fun. I got to go back and read medical journals from the 1880s. It's kind of like listening to your grandfather, because of course it's a male voice. Grandfather like tell you about stuff. And so this is apparently it's a great treatment for eversion, ulceration, congestion, patulous os, and uterine catarrh. I also saw a reference from the 1950s using it for incompetent cervix, but none of the people who are currently doing women's health that I spoke to had ever used this code. So it appears to be more of a historical code. So it doesn't appear to be medically necessary. And then uterine septum, based on both expert group and expert opinion that staff, from a local expert that staff reached out to, it appears that the expert opinion is resection should be done for recurrent pregnancy loss or menstrual bleeding disorders. There is some concern from the agency about covering for infertility indications because of a lot of restrictions that we have on infertility coverage. So the staff recommendation is to place this in the menstrual bleeding code grouping, which would allow resection if there's blocked menstrual flow, and then a guideline saying that that infertility indications are essentially outside of the benefit package. Does anyone have concerns? So what will happen from this is there will be a benign conditions of female genital organs that will have all of the Birthland cyst codes in it, and destruction of vaginal lesions and some other treatments. The post-endometrial ablation syndrome will go in menstrual bleeding disorders, which has hysterectomy codes. And then we're going to be modifying a few guidelines. The pelvic congestion syndrome um, is not going to be paired with anything. It will be in the evaluation of medical management, so that guideline's no longer needed. And then chronic inflammatory conditions will be evaluation of management, so they will no longer need a guideline. Opportunistic self-injectomy just needs its typical the formulaic kind of changes to match the BUP format. And then there'll be a new guideline for uterine septum saying that it's medically necessary to treat menstrual outflow obstruction, but the use of the procedures for infertility invocations is not a covered service because infertility is outside of our benefit package.
I have one other question.
Of course.
The for the N94.89, so all of the conditions that are listed there,
Mhm.
is is there anything besides the problem with the canal of Nuck that would require surgery of a surgical procedure and not just evaluation and management?
I mean, they may need some diagnostic testing, like a vulvar mass.
Okay.
That would be those are diagnostic. The hematocele, those are more of like a large bruise, erosions. I mean, some of those, if you had like an erosion of the labia, you may be worried about like a precancerous or cancerous condition, but again, a biopsy would be covered.
Okay. All right. I just want to make sure that we don't, if a clinician suspects something, I would not want them to be limited to just evaluation and management if it's appropriate to do something more.
Yeah, the diagnostic tests, like a diagnostic excision, a biopsy, those types of things should be covered. That's a diagnostic procedure.
Okay, great. Thank you.
Deb, I see your hand.
Um, this might be a question for bigger picture and for a different time, but thinking about the uterine septum, if that doesn't, if there is a pregnancy involved with pregnancy, so it's not a matter of infertility, but it's creates a complication in a pregnancy and delivery. Could a uterine septum create a complication for the mother's health in a pregnancy?
I mean, typically what happens is the septum sort of decreases the maximum size of the uterine cavity. So frequently those babies are breech, need to be worked by a cesarean, or they may have growth restriction or preterm delivery. But we can't
Okay, so
remove the
that's
septum with a pregnancy in the uterus. It has to be done between pregnancies or
you're right, exactly. So if someone had a pregnancy, realized, oh, they have a brain, sorry, uterine septum, or that would be something if they went. Yeah, maybe there's a nuance of language of when does it become a health of
when
the
is it
mother or baby,
infertility? Yeah.
and then what is infertility. But I hear you saying too that the complications are addressed, what could be addressed with C-section, that
I mean,
it's not going to be a late term miscarriage.
I suppose if you had
Or
like you'd had a
preterm.
preterm baby and you were planning another pregnancy to reduce the risk of a preterm, but I think that could also be handled by exception. I'm looking at you, Kat. Would that be
Okay.
something that you would look at as an exception? Or is that something we should put into the guideline? I'm picking on Kat because she's a medical director.
I see Holly Joe on it. Can I?
Oh, and Holly Joe too. Yeah. Holly Joe, you're welcome to come off mute and tell us any thoughts you have.
I'm not sure how to make that more simple. And unless you added some sort of a line or a guideline note that said in women with a history of a preterm pregnancy, it would be covered. But I don't know. Are we that worried about it being done for infertility reasons? It's pretty rare.
My initial guideline didn't have that, and then other parts of OHA thought that that would be a good idea.
I'm not very worried about it. Are you, Kat?
I'm not,
Mark?
I'm not, yeah. Oh, Mark. Yeah, I'm not particularly worried about it. I mean, it seems like recurrent pregnancy loss or preterm labor, or there might be a number of reasons that a septum would need to be potentially removed.
I mean, we could just not have a guideline. We could just leave it open and then,
Yeah, it just has to meet medical necessity if you want to put a PA on it. I'm good with that too.
okay. I think that would be reasonable. Because, yeah, and then you have to think like, is it one preterm delivery or multiple preterm deliveries? Or,
We don't want any preterm deliveries.
right,
Yeah.
yeah. And if we do this and it helps someone get pregnant, but then they don't deliver prematurely, yeah.
It's
So
all in.
So we could modify this and we can just remove that guideline. This would still put the uterine septum into the menstrual bleeding category, which does have all the codes that you would need to resect it. So it would just sort of come through as I have a uterine septum. I want to do the uterine septum surgical procedure, and they would pair and in a CCO or fee for service could write guidelines. Anyone want to argue to keep the guideline, or are you all comfortable with not approving, not having a guideline?
I'm comfortable with not having a guideline.
Okay.
I'm comfortable with that too. I'm just reading the miscarriage, preterm birth, increased rates of C-section. Individuals with a septate uterus have a higher risk of miscarriage, 35% versus 10 to 20% who don't have uh, a septate uterus. And that's pretty significant to me. And it doesn't say anything about long-term effects of that. So I think removing the
Or not having a guideline.
not having a guideline, I think, is very appropriate.
Okay.
I'm fine with that.
Okay. So if you want to, I'm sorry, I missed somebody.
I said I am too. I'm comfortable with that too.
Okay, so it seems like we're pretty unanimous. No uterine septum guideline. It will just be paired with resection, and then if we have problems in the future, we can address it. Okay. And then anyone have any questions about any of the code tables? The things that are highlighted are things that had questions. I just wanted to make sure that they were highlighted so folks could see them. If you're all comfortable with this proposal, except for vulvar polyps, which we're holding until Mimi can join us, we could vote on it, I guess, and then hold with them one modification and then holding any decision on vulvar polyps. Does that sound like what you want to do, Linnea?
Sorry, hunting for my mute button.
No worries.
It's a daily task. I think if we can, let me phrase that correctly, that we would like to move this forward without a guideline note, with the one exception that we want further clarification later today. I want to leave it so we're not hanging longer than that. Does that sound right, Jason?
Yeah, we could table the vulvar polyp question, vote
Yeah.
on the modified proposal, and then we
Yeah.
can circle back to the vulvar polyps.
Okay, so the as presented, except for vulvar polyps and deleting the uterine septum guideline.
Yes.
So moved.
Second.
All right, we'll have to call the roll and get your votes.
Okay, let me get to my roll list here. Mark,
Approve.
Deb,
Approve.
Larry,
Approve.
Pat,
Approve.
Leslie,
Yes.
Linnea.
Approve.
Oh, Devin, all right.
Approve.
Great. Did I miss anyone? I think that's everybody. Okay, motion carries.
Great. All right, then we have two separate gynecology or hysterectomy topics that HERC folks asked me to do a deeper evidence dive into. So both of these, both chronic pelvic pain and dysmenorrhea, have hysterectomy currently paired with them below the funding line with guidelines. However, there was concern that particularly chronic pelvic pain, but dysmenorrhea as well, it may or may not effectively be treated with hysterectomy. So chronic pelvic pain is relatively common. It is, by definition, something that doesn't have a known etiology. Many people with chronic pelvic pain end up having endometriosis or adenomyosis if they have surgery, or, for example, to figure out the cause of their pain. Sometimes it's actually GI origin. Sometimes it's neurologic origin. There's many types of things. Typical treatment for chronic pelvic pain includes medications such as NSAIDs, hormone medication, antidepressants, and then nerve agents like pregabalin and gabalin. Pelvic floor physical therapy and cognitive behavioral therapy can be beneficial, and then surgery like hysterectomy is done in some cases. So this was reviewed by this group in February, and then further at HERC in March. The current placement, which is an extremely low priority line, was done in 1996. Hysterectomy was not initially on that line. It was added in 2000 or 2001. It was difficult to tell from the minutes because of a provider request, but it was maintained at a very low priority placement. The last evidence review for treatments for chronic pelvic inflammatory conditions was in 2013, and all the appropriate treatments were felt to be already on that line, but the line was not reprioritized. So currently it's line 525. There are known causes of pelvic pain, for example, endometriosis, abscesses, etc. They're on various covered lines. Hysterectomy is on many, many lines. You can see the current chronic pelvic pain guideline. It's kind of our standard hysterectomy guideline. And then looking at the evidence for this, there was a systematic review and meta-analysis that was published this year on non-pharmacologic therapy for chronic pelvic pain. They essentially looked at pelvic physical therapy, which was found to have a clinically significant reduction in pain. And then there was a statistically significant change in health-related quality of life, but it was not clinically significant. And then they looked at cognitive behavioral therapy that basically found some conflicting results for health-related quality of life. Acupuncture was found to have little difference. It was essentially favored the control. And then there were a few other things that were found, like low-level laser therapy, that were looked at, but none of those were considered to be very effective. So essentially from this meta-analysis, it appears that physical therapy is clinically significant improvement in pain and health-related quality of life, but no clinically significant improvements were seen for cognitive behavioral therapy, acupuncture, TENS, or massage. There was a 2021 Cochrane review for surgical interventions for chronic pelvic pain. And they were uncertain if adhesionolysis would affect pain, although it may improve emotional well-being. And then they were uncertain about the safety for adhesionolysis. Adhesionolysis is when they go in and they remove scar tissue that may be connecting various organs in the pelvis. Uterosacral ligament ablation. They were uncertain about how effective this was for treatment, and essentially they said there may be some benefit in quality of life, but they were very uncertain based on their current evidence. And then an older Cochrane review from 2014 looked at medications and psychological treatment, and they found moderate quality evidence supporting hormonal medications, and yeah, essentially that. Looking specifically at hysterectomy, they're older, from 2012 and 2011, older systematic reviews. Basically, a systematic review from 2012 found one poor quality prospective cohort study, and their conclusion was that there is insufficient evidence to determine if hysterectomy is helpful. There was another review in 2011, and they basically looked at really old studies from 1990 and 1995, and they found that some women in these studies reported a decrease in pain, but quite a few women actually had an increase in pain or persistent pain. And they specifically called out the people who are more at risk for persistent pain were younger or covered by Medicaid. And yeah, and the continued pain was up to 40% of women, and 5% had increasing pain. So ACOGs does recommend pelvic floor physical therapy, cognitive behavioral therapy. They recommend various medications, trigger point injections, and they note that acupuncture and yoga may be considered, but they actually don't recommend surgery. They don't mention it in this guideline. They have another guideline specifically for adolescents with chronic pelvic pain, and they call out that there should not be surgery in that group. For women over 18, they are silent, essentially not promoting it, but not saying that it shouldn't be done. Most private plans do cover some type of hysterectomy. So, in summary, systematic reviews and meta-analysis have found evidence that pelvic PT improves pain and quality of life. This is recommended by ACOG. Medications are also helpful, again, recommended by ACOG as well. There is no evidence in the systematic reviews for cognitive behavioral therapy, although this is recommended for ACOG, although they do call out that it works better in women with coexisting anxiety or depression. Acupuncture TENS and adhesiolysis are not effective and not recommended. Hysterectomy is very poorly studied. Based on some very old cohorts from 30 plus years ago, there is a high rate of continued or worsening pain after hysterectomy. Based on all the evidence review, staff is recommending making pelvic pain pair with PT and OT services for pelvic physical therapy, but not any surgical interventions. That would be consistent with vulvodynia and similar diagnoses that we reviewed last year. Medications such as hormones, gabapentin, all the other types of medications that were recommended would be available to be covered. If this is what you agree with, then the staff would recommend that you place pelvic and perineal pain in conditions benefiting from PT and OT, that there are no hysterectomy or other surgical codes in this code grouping. And then we would delete guidelines about essentially chronic pain syndrome with all of the hysterectomy guidelines in there. And then there are several different other diagnoses, which are all recommended for evaluation and medical management other than the pelvic and perineal pain.
I have a question about 3 of the diagnoses. I'm looking on page 34, and the diagnoses N71.1, N73.1, and N73.6. And in light of the anxiety and depression, that can be related to these conditions, just from a clinical standpoint, I just wonder how many of these patients are evaluated for some type of traumatic or abusive experience, where therapy really may be very helpful in terms of managing their condition. But my other question about these three specific diagnoses is, are these always appropriately treated only with evaluation and medical management? Would any type of procedure be appropriate for any of those? I'm just wondering, and I'm wondering if we can get an expert, or if we have an expert opinion on that.
Yeah, so the first question about trauma, I think anyone dealing with patients with chronic pelvic pain are very aware of the relationship with previous trauma and appropriately try to deal with that. I did actually ask that question about the chronic inflammatory disease and parametritis to our gynecology experts. I was told that these diagnoses can only be made after basically it's pathology after surgery. So you wouldn't be doing an intervention for this. You would find this on like your hysterectomy specimen.
Okay, great. Thank you.
Kat?
I'm noticing that the guideline note has criteria for a diagnostic MRI, and that's
Oh, yes, that might be useful to keep, right?
yeah, that was
But
my so if it goes on to evaluation and management, we would still want the diagnostic MRI guideline, right?
but it should probably become a diagnostic guideline.
Okay. Yeah.
Make top half of guideline diagnostic.
So just the ones that Liz is showing, B.
It would be, it got strangely numbered. It would be B.
It just pasted weird.
Yeah, so it would talk about MRI is indicated if you've got all of these symptoms and you've had an ultrasound first. So I will take what's listed under B and 8, 9, 10. Sorry, there was just some strange copy paste there. That will become a diagnostic guideline. And then hysterectomy, which is C and all of its pieces after that would be deleted.
Catch.
Good catch.
That's not a friendly amendment that we want to make now. This is something that we want to bring back.
I think it can be a friendly amendment because the wording is already there, and then we can bring it to HERC and make sure, or do you all want to see it again in its final form before you approve it?
Should we just read it aloud just because it's struck through? Won't take long. So diagnostic MRI may be indicated for evaluation of pelvic pain, to assess for adenomyosis, and to assist in the management of these challenging patients when all the following are documented: patient history of dysmenorrhea, pelvic pain, or abnormal uterine bleeding for more than 6 months with a negative effect on her quality of life. And can you go down, Liz?
Failure of a 6-month therapeutic trial with both of the following unless there's contraindications. 1, hormonal therapy, which can be pills, patches, IUD, injectable therapy, or agents for inducing amenorrhea, such as GnRH analogs, and NSAIDs. And then, unless contraindicated to our patient who wouldn't be eligible for NSAID therapy. And then you would also need an endovaginal ultrasound within the past 12 months that shows no other suspected gynecologic pathology. If the diagnostic MRI shows greater than 12 millimeters thickening of the junctional zone.
I thought that was the criteria for the diagnostic MRI.
Can I make, yeah, I think let staff work on this and just to make sure that we look at all these pieces, and I need to pull up guideline note 39 and whatever else is there, and we will work on perfecting this.
Okay. And I might suggest just a little word change of if we can get rid of these challenging patients, maybe we can say of this challenging clinical condition or something. Anyway,
I think we don't even need of these challenging patients. That just seems strange.
Delete it. Thanks.
Yeah. I have a quick question about the guideline also. When staff review it, does it need to be so granular? I'm just wondering.
Yes.
And I think this is pretty consistent with MRIs for other areas of the body. We'll ask for things like PT and a trial of NSAIDs or muscle relaxer. I don't know whatever we say.
Okay. The other question I have is, does it have to be 6 months if someone has increasing pain and significant interference with quality of life?
I think normally what you do an ultrasound first, and if the ultrasound shows like a large ovarian cyst or, something that you're looking for causing pain. I think this is more for people who have persistent pain.
All right. Well, let's see what staff comes up with. That sounds fine.
Okay.
So we'll bring this back to September.
Well, we can approve it with staff working on the pelvic pain guideline to come back into September. Do we want to do that, or do you want to just table the whole thing?
Oh, no,
Oh.
no.
Go ahead,
Go
Larry.
ahead. Yeah. No, I think to approve it and then with the proviso that staff works on this particular thing so we can get the other parts of it done, I think that's fine. What say others?
This is Leslie. I agree with that as well. Let's get done what we can and take back the rest.
Agree.
Okay.
Yeah, sounds fine to me too.
Same.
Okay, so you are voting on everything except deleting guideline 55. That's tabled. We're modifying guideline 55 heavily. Anyone want to propose a vote?
I propose a motion as Ariel just said.
Refresh me on that motion.
So you are approving the staff recommendation to place pelvic and perineal pain in the PT-OT coding group, but not paired with hysterectomy, and then all the other coding changes that were in that table. But we are tabling the deletion of guideline note 55 to come back to you all with wording modifications.
That has been moved, and we need a second.
I can second by Deb's hand.
I had a question about see if I see it on the screen there to read it. So it's going to be a group with PT and OT services with strong evidence, but not with a surgical group code grouping for the pelvic floor pain or pelvic pain. Did I hear you say too it would be chronic pain, yeah, the chronic pain management, just like a generalized physical pain, and yeah.
So it's very consistent. We discussed sometime last year vulvodynia, which is pretty severe pain in the external genital organs, and this would be consistent with what the decision was from there. It would sort of
Gotcha.
be PT-OT. If the patient has coexisting depression, anxiety, trauma history, whatever that would need therapy, they would obviously have access to those services.
It
Okay.
could just be under a mental health diagnosis, not.
Yeah.
Yeah.
These could be a secondary diagnosis or something.
Yeah, this is talked a lot about in the acupuncture world, and it's challenging to do acupuncture research just to get a sample size large enough. But I don't think there's strong evidence, so that is something for later. But also thinking about the pain management. But okay, I'm good. Thank you. Thanks for letting me talk that out.
So we have
Right,
a
ready for me to
first,
call
we
the
have a
roll?
second, and so we can call the question. Should we take roll call? Yeah.
I think Kat gave a second. So I will call the roll. Mark,
Agree.
Deb,
Agree.
Larry,
Yeah, approve.
Kat,
Proof.
Leslie,
Approve.
Devin,
Yes.
Linnea.
Approve.
Great, motion carries.
Great. All right. Then now we have our a similar evidence review for dysmenorrhea. Dysmenorrhea is pain with the menstrual cycle. And currently, this is very common. It's typically treated with birth control pills or other hormonal contraception, NSAIDs, heating pads, etc. When those aren't effective, endometrial ablation and hysterectomy are sometimes used as sort of last resort treatments. Um, so dysmenorrhea or pain with menses can be related to things like fibroids or endometriosis, in which case there are treatments that have been shown to be effective. So we're talking about dysmenorrhea that doesn't have a underlying pathology identified. This was again discussed here in February, and HERC wanted to do a more in-depth evidence review, which is why you're seeing it again. It was reviewed in 2013, and acupuncture was actually removed because it didn't have evidence of effectiveness. It was placed on its current low priority line in 1994. We reviewed it as part of the ICD-10 conversion in 2011-2012, and there was no suggestion to change the placement of it. It's currently on line 551 and has a hysterectomy guideline. And looking at hysterectomy treatments, there was a review in 2024 that talked about first line being NSAIDs and hormonal treatments, second line being like suppression agents like GnRH analogs. There is evidence on physical therapy and heat, mixed evidence on acupuncture TENS or supplements. And then looking at surgical options, there people have tried presacral neurectomy, and they felt that further research was needed on this. Uterosacral nerve ablation had mixed data. Endometrial ablation had a significant reduction in pain in women who also had heavy menses as an indication. And then hysterectomy is reserved for patients with dysmenorrhea from causes like endometriosis who have failed conservative management. And then they basically note that it is done as a last ditch effort. There was a Cochrane review last year on TENS unit that found very uncertain evidence about TENS units. There was a 2016 Cochrane review on acupuncture that found insufficient evidence. And then there was another Cochrane review from 2010 on interruption of pelvic nerve pathways that also found insufficient evidence. Looking into evidence specifically on hysterectomy, there was an RCT done in 2015 where they randomized women to hysterectomy, but it was essentially total hysterectomy versus supracervical hysterectomy. So taking the entire uterus and cervix versus just taking the uterus but leaving the cervix. They did note a large percent of the patients, at least a quarter, had fibroids. And then there was a pretty significant reduction in pain in both groups, which would make sense. There's not a lot of difference if you leave the cervix or not for both quality of life and pain. And they did find endometriosis and adenomyosis in another large percent. But they did note this, so the sample size was very small. They had 59 women, and that many of these women who had some type of pain had endometriosis or adenomyosis or other etiologies. In terms of expert guidelines, Hysterectomy is listed as a possible option by ACOG, particularly if the dysmenorrhea is related to fibroids, endometriosis, or adenomyosis. But they don't recommend discussing it if it's just dysmenorrhea with no underlying cause. But again, in the adolescent, they recommend that you do not do hysterectomy. The private plans that I could find that had written policies did not cover hysterectomy for dysmenorrhea without another cause. So in summary, there's good evidence that NSAIDs and hormonal therapies are effective for treating dysmenorrhea. There's very little evidence for non-pharmacologic interventions for dysmenorrhea, including acupuncture, TENS, sacral neurectomy, etc. There was only, specifically looking at hysterectomy, there was a single study found with 59 people. It did find some improvement in pain and quality of life, but again, very small. And many of the patients were actually found to have conditions that we already cover hysterectomy for, such as fibroids, endometriosis, or adenomyosis. Based on this review, staff are not recommending pairing dysmenorrhea with hysterectomy, TENS, acupuncture, or sacral neurectomy due to lack or minimal evidence of effectiveness. Hysterectomy could be approved by exception if it was a last-ditch kind of case. And so the effective things that would need to be done would be to place the single code for the set of codes for dysmenorrhea to the evaluation and medical management group, which would not pair with hysterectomy, delete the guideline, and that's all. Questions?
So this could be approved by exception. In general, how difficult or drawn out or is the exception process?
I think it's a case by case. If you have some very clear cut exception, I think it can go through pretty quickly. I think in a case like this, which is purely dysmenorrhea without any other pathology seen, I think there would have to be a pretty persuasive argument.
Are there any standards or requirements, especially in terms of time frame, for the exception process? Not just for
Mark or Holly
hysterectomy.
Joe?
Hey, Lori, when you say exception process, we have a standardized PA and appeal process with very specific timelines, requirements, and compliance on all of those that need to be adhered to. So there is standards for those.
Okay, great. Thank you.
Yeah.
So I have a quick, I mean, I generally agree with the staff recommendation. So in the study that compared two different types of hysterectomy for dysmenorrhea, how many people improved?
I would have to go. It was a very poorly reported study, I would have to say. They were looking more at like overall changes, and
I mean, the reason I ask is because, I mean, this is going to reflect my ignorance because I don't, this is not a clinical population I deal with at all, but if getting rid of the organ that is the presumed source of the pain, you would think would, result in a relief of pain in almost everyone. So anyways, I was just curious, which, is a roundabout way of asking if the condition of dysmenorrhea that's not associated with any of the other conditions that you described is hard to treat, partially because it's difficult to anatomically define and pinpoint. Anyways, long-winded way of saying I agree with the
and in my non-expert, clinical practice, I would say that once you get down to like pelvic pain or dysmenorrhea that's severe enough that a patient wants a hysterectomy and they don't have any other etiology, it almost kind of falls into the chronic pelvic pain bucket.
That's what I'm wondering. I mean, it seems like, again, so if you do a trial where everybody has that organ taken out and still you have people left with pain, it does seem like it would veer into this other territory. But anyways, no argument for me
Would,
on the
wouldn't
recommendation.
it also depend on the degree of pain reduction also?
Well, and remember when you do a surgery like a hysterectomy, you're also causing scarring, you've got other complications. I mean, there's other things that happen.
Right, right. There's a risk to make things worse. Yeah.
Any other questions or discussion?
Do we need a motion on this?
Yes, please.
I move to accept.
The staff recommendation as presented.
Yes. Thank you.
Second.
Go to vote.
Oh, I do have some concerns of acupuncture not being covered for dysmenorrhea. 'Cause I work with that a lot. Can I vote? Can I vote? Is it consensus?
You
If I
may
vote
always
no.
vote however you feel.
Yeah, thank. And I assume it's. I know the evidence reviews are I am so amazed and impressed by everybody doing the evidence review, but also considering then that the one study was saying that the acupuncture and TENS was not superior to the NSAIDs and the existing treatment, but would be, but because there was no significant difference, but could be then considered comparable, and less complications in hysterectomy. That's where my reservation comes from.
We
But I'm
just
willing to vote.
reviewed this
That
literally
was
last month. We reviewed acupuncture for a variety of things.
Yeah, and I was,
Um,
and I know folks that were involved with that, so I also trust the process.
yeah.
It was not the Cochrane from 2016, but it was the 2024 Kirsch.
Yeah, and so there was a Nielsen systematic or an updated Cochrane review from 2019 that found inconsistent
Yeah,
for
understandable.
dysmenorrhea. Yeah, I'd have to go back and look through that whole review that we did in May. But I
And I know that
remember
was done. I know a ton of work was put into that. So, and I know there's some good work that was being done on it.
Okay, Renee, are you ready for the call roll? Yeah. Okay. Mark,
Agree.
Deb,
Disagree.
all right, Larry,
Agree.
Kat,
Agree.
Leslie,
Yes.
Devin,
Yes.
Linnea.
Yes.
Great, motion carries.
great. So in terms of women's health, we will bring so once Mimi gets here, we will ask about the vulvar polyps, and then we'll have two of the three ready to go to HERC, and then, well, all of them will be ready to go to HERC except for the chronic pelvic pain MRI piece that we need to continue to work on. So if Jessica or Liz or someone just flag when Mimi joins us so that we can kind of take a little break and go back to gynecology. That would be great. We can move on to dermatology. So uh, we talked about this at our April meeting. There was some concern with this group about general dermatology. You wanted cysts, scars, granulomas, and keloids to have further evaluation and be brought back. So there's a separate issue for that. We've already talked about viral warts and paniculectomy. You already approved those. Those are on the HERC agenda for next week. You also approved the current guideline for actinic keratoses. But after the EBGS meeting, our P&T, our pharmacy colleagues, reached out and had some concerns about some of the of some treatments that involve medications that we had not addressed that they wanted us to address. So you'll be seeing that kind of come back. And so, and the main overriding thing that this group was uncomfortable with the sort of general dermatology topic, was that you had felt that staff were lumping things too much, and that the procedures were being mixed together with, there was sort of a large group of procedures mixed with a large group of conditions, and that wasn't appropriate. So staff have kind of pulled them back out into their kind of more current line structure, which will become code group structure. And then there's a lot less sort of changes that we need to make. So the things that we still need to talk about are pseudofolliculitis barbae, which are small, they can require abscesses, and it's basically similar to severe acne. Hyperhidrosis, that is brought back because of our pharmacy colleagues having concern for pulmar hyperhidrosis, that they felt that only axillary hyperhidrosis has effective treatments with, for example, Botox or other medications. Although I think for pulmar, you can still use some of the topical medications, but so that the recommendation for that is coming back to kind of look at a little bit further. And then we talked about this at our last meeting. Experts really would like us to cover wigs for people with alopecia. We currently only cover them for cancer treatment. We have talked to folks internally at OHA, and we continue to recommend that we don't cover them for anything other than cancer because of current CMS rules. And then hyperhirsutism and hypertrichosis, which is too much hair. The experts wanted electrolysis and laser therapy when severe. However, OHA feels that our current OAR excludes these services because they're primarily to improve appearances. So the recommendation is not to move forward with that. And I just wanted to highlight that we did get one public comment in support of this coverage, and you all should have received a link for that if you want to read that further. And then most conditions are going to be essentially the same. So what we are proposing doing, it's kind of a backing up from what you saw last time. There'll be a code group inflammatory skin disease that will be based mainly on our current line 423. There'll be some additional ICD-10 codes that will be placed in this grouping. Many of these are the more minor forms of some of these conditions, and we'll maintain our current guideline that many of the procedural interventions or medications that need a PA would be restricted still to more moderate or severe forms. And then we would put axillary hyperhidrosis in the hidradenitis suppurativa group. I know it's not exactly works, but it has the chemo intervention CPT codes there, and we can attach the chemo intervention guideline can be applied so that we can cover Botox for that area. And then there'll be a whole bunch of codes that will just be evaluation of medical management, and then technical changes to the current guidelines. One piece that I did actually want to call out in case anyone wants to discuss it is that there is a HCPCS code for dermal filler injections for facial lipodystrophy. The proposal is to exclude as cosmetic. Facial lipodystrophy is a complication of HIV disease, and facial lipodystrophy is currently on line 12, so that would be one other place we could put it, would be on line 12 if people felt that it would be an appropriate treatment. So you can see here the hemangioma guideline would essentially just have the usual technical changes. The severe inflammatory skin disease guideline has mostly technical changes. There are some changes that the experts recommended. For example, we have treatment is only medically necessary when you are moderate or severe, and then otherwise these conditions are on unfunded lines. They felt that since the intent is to still cover antihistamines, topical steroids, et cetera, for these conditions, that we should call that out, that these are things that are still treated for those conditions if they don't meet the level of severity to qualify for PA medications or procedures. And then for severe atopic dermatitis or eczema, there are a lot of medications called out in the current guideline, and the experts had a lot of questions about this and that. And essentially, talking to our pharmacy colleagues, we thought it would just be better to just delete all of the wording about drugs, leave that up to the pharmacy folks to sort out, and we would essentially say for severe eczema, topical and oral medications and phototherapy are covered, and then targeted immune modulators would have specific requirements. And then there's a non-specific ICD-10 code that's only on the line for one thing because it's only needs medical management. We don't need that anymore. And then there'll be just some wording changes about the severe exfoliative disease just to make it flow better. And then at our May meeting, there was wording about patch testing for allergic dermatitis that was approved. And the they at the May meeting, they crossed out moderate to severe. They only wanted severe to be in there. So that's just for your own information about why you're seeing that again. Moving on, severe cystic acne will just get technical changes. Same with guideline note 132 and guideline note
Larry
1.
has his hand up.
Yes, Larry?
It's okay. I'm comfortable waiting until you go through all this. I have a question about hirsutism, but I'm comfortable waiting. Go ahead.
Okay. And then hidradenitis suppurativa, again, technical changes. And then our chemodenervation guideline, which is a very long guideline. This is just the excerpt, would say that chemodenervation is medically necessary only for treatment of axillary hyperhidrosis and not pulmonary hyperhidrosis. And that's based on our pharmacy input. And then looking at, as you can tell, almost all of the diagnoses will end up on evaluation and medical management, except atopic dermatitis, which was already, we have some versions of it already on the inflammatory skin disease guide. It will all just be an inflammatory skin disease. And similar to contact dermatitis. There's a few that are going to be on the allergy world for allergy testing that were reviewed under that type of topic. So you'll see some that are referring to allergies. And then there'll be some conditions which are hair loss, like alopecia, like implant, all of these that will become not medically necessary. And that's because of current CMS rules regarding cosmetic conditions and hair loss. And then this would be, I guess, where Larry, your question about hirsutism and hyperhidrosis. I think we're at L68, next page. Yep, right there. And that's being referred to not medically necessary right now.
I have a question about the hirsutism because that's associated with a couple of other conditions. And I know that there's an exception process. So what I'm wondering is if hirsutism could be treated by exception if there was evidence that the hirsutism significantly interfered with one's normal functioning, and not just on a physical or a medical basis, but also on a behavioral basis.
We'd have to write a guideline for that, which we could do if folks were interested in that.
I'd be interested in that. This is Leslie. I think it's important to think about with both this and the wigs for alopecia. anytime we talk about that's something that's just changing appearance, I would always urge us to dig deeper and think of the whole person and how it would be impacting their daily activities, how it's showing up in their behavioral and mental health status, and things like that. So I think with both of those, it's not enough just to say it's changing appearance, full stop. We're not going to do anything there. I think we need to look a lot deeper and look at the whole impact on the person's physical and mental health as well.
And referring to wigs, there are very firm CMS rules that we would have to apply for an exception for to cover wigs for anything other than cancer. Um, it's not even would be cosmetic. It's basically it's outside of any benefit package
Wait,
unless
I thought that was just for the medications. Is that for wigs as well? Okay.
that's what I recall. We could look into that, I
I
guess.
guess let's double check that. But first, let's see, are there others interested in that, or is it
I
in
see Mark's hand up.
yeah.
I do have a question, but it's not on wigs. Can I-
Anyone else have any concerns about the hirsutism? I mean, we could make it evaluation of medical management. Are you all?
I think that I mean I don't disagree with the points Leslie and Larry are making. But it does open a can of worms in the sense that there are a lot of things that fall into that category, right? I mean, I'm actually pretty empathetic to the argument that there are things that are, related to one's external appearance that affect your internal, way of being. But there's a lot of things that fall into that category. And so, anyways, I don't theoretically disagree. I mean, I just have some concerns from a practical standpoint on how we would approach that, because I think it will end up affecting a lot of different potential things, not just these two things. And it would be hard to figure out when something rises to the level of affecting somebody in a profound way versus not. So anyway, I don't have a clear answer.
Sorry, I'm just going to remind the group that we are looking at electrolysis for cisgendered women next weekend, VBBS. And I think
It's not on the agenda.
for next week.
No.
Oh, I apologize, but that's a topic that's coming.
No, we've been thinking about having it, but we did get a public comment on it this week. Maybe that's what prompted you.
Okay.
So I think it's wise to be mindful of, is hirsutism unto itself problematic, or is it, I'm sorry, Mark, you have your hand raised. I just couldn't see it on your bookshelf there. Go ahead, I'll speak after you.
Oh, I wanted to switch over to the atopic dermatitis.
Okay. Well, I'll just finish then, and I'll just say that, there's folliculitis. There's other kinds of things that sometimes are comorbid with hirsutism. And so I think it's maybe we default to where there are other conditions where it is causing difficulty, and not standalone hirsutism. That would be my recommendation, not to go down the road of making that a condition. So Mark?
Oh, just a clarifying question on the atopic dermatitis. I understand it will be on an E&M code, but for medications, how are those different? Who makes the rules for the medications for atopic dermatitis?
So currently we have guideline 21. You
Right.
have to have a certain quality of life score. And then if you don't reach that, then oral and topical antihistamines, topical steroids, and over-the-counter medications would be covered. And then for severe, then the guideline is the same. We just are striking out all the different drug names because it's too hard for us to maintain those. So your pharmacy folks should already have PA criteria for the expensive topical steroids or the high potency or something. And this, according to this guideline, only if you have a certain functional impairment on your quality of life score, or it's 10% of your body surface area or your hand, foot, or face.
Correct. For medications.
For any treatment other than over-the-counter medications.
Correct. Okay.
Hirsutism for a minute. I agree with Devin that, and this is a slippery slope. What I would like to see is some expert input from endocrinology, from OBGYN, from people who treat people, from clinicians who treat patients who have conditions where hirsutism is one of the effects of the condition. And what do they see? What do they recommend?
We've already talked to them. It was in the staff summary up above. They feel that they should be treated with electrolysis and laser therapy when severe. I'm not aware though of a scale that would really tell us if when it's severe. I think they kind of define severe as impacting people, it's quality of life. I could try to see if like you could use the dermatology quality of life like we do for our severe inflammatory skin disease guideline, but that's designed for things like psoriasis and eczema. I'm not sure if that tool is designed for hirsutism.
Let me ask, okay, then has there been any, and I'm sorry if it's already there, has there been any expert input on how significant the hirsutism I guess that they would say it is significant, which is why they recommend the electrolysis. I'm not sure what to do with this.
What we could do for today is if you're comfortable with everything but hirsutism, we could table hirsutism and bring that back in September for further discussion.
What would we do about the hirsutism in the meantime? Is there any other information we could gather?
We could reach out to the person who provided public comment. We could reach out to experts. We could try to come up with options that you could consider.
See what other states are doing.
Yeah, see what other states are doing.
Great. I would love that. I think that sounds great to me. What do others think?
This is Leslie. I like that idea. I thought the public comment pointing to I couldn't tell if they were studies or if it was kind of anecdotal information about the impact on mental health and behavioral health I thought was important. So I think taking it back and doing a little bit more research would be great. Thank you.
Yeah, I did look at that. There was a comparative case cohort done in a sample of dermatology patients, so not general population. But it showed that the more severe the hirsutism, the greater the impact on some of those outcomes. But we could do a little more searching. Just there may be other studies with different results.
Yeah.
It does seem like the location of the hirsutism is important, where there's greater impact in terms of people's social functioning if it's on the face versus other body parts. So that would be just important to consider as part of the review.
I mean, I also wonder if this is, we talked at the retreat about using some local data to guide some of this in terms of, how widespread an issue this is in Oregon, and whether that should help guide things, right? So things that are not likely to be super resource intensive, either because the treatment itself is not expensive or there's not a lot of people affected by it. Um, you know, I think we have more room to err on the side of coverage than
I
the
do
condition
know
for
from our
which
gender affirming treatment work, electrolysis is hard to access in the medical billing system. People with, you can get it at I don't know if it's called a spa or, non-medical over the counter, but to get it billed by somebody with the infrastructure to bill Medicaid is difficult. So we wouldn't probably have it in our data sources. We might have prevalence information when it's coded on the claim, but it's actual electrolysis.
No, I meant just the prevalence information, but
Okay, okay.
Yeah, I know there has been requests in the past, so this is something that there is some some d demand for. Uh, and one of the treatments would be like birth control pills or other hormonal treatment, especially if or treatments for conditions like PCOS that result in hirsutism. So you've got some pathways there, but we can definitely do a deeper dive, look at state policies, private payer policies, look at the CMS restrictions on cosmetic and hair, those types of things.
Sounds great.
And then
yeah,
I also have a note about wigs that
Oh, wait,
Leslie,
Devin wanted to say one more thing on this one, I think. Did you have one more comment on this, Devin?
no.
Oh, sorry.
Well, yeah, no, it's nothing important.
Okay.
so I also made a note about the wigs. We can table the wig guideline and wig discussion and bring that back as well
I think
and get a
wigs
little
are,
more
I've
information.
looked and I think medications for hair loss or hair growth would require a state plan amendment. Wigs are an optional benefit, so it would fall into that if money allows situation, even if you were to add it.
Hey, Jason, what do you mean by state plan amendment? Is I know the term, but it's not
Sorry,
changing
getting a little
everything.
weedy here. So a state plan amendment is our agreement, the state of Oregon's agreement with the Center for Medicare and Medicaid Services about what will be covered under Oregon's Medicaid program. There are certain benefits that must be covered, like physician services when medically necessary. Certain other benefits are optional. Examples are physical therapy, mental health treatment, acupuncture, um, chiropractic. I'm missing some, I'm sure.
Podiatry.
Podiatry. So those can be covered at state's discretion and can receive federal matching funds, but states don't have to cover them. Oh, dental is the other example. And so, in a tight budget environment, those are generally the first thing to go, even if, just as eyeglasses is another one that's in the funded regional priorities list, but is not covered for budget reasons. So some of these things would fall into that range. But we can bring it back and we can discuss it. I just want to be transparent about the situation.
No, thanks for that clarification.
Mark, I posted the link to Oregon Medicaid's state plan in the chat if you want to.
A little insomnia cure there.
So I have in this general dermatology, I have tabled wigs and hirsutism. So basically the guideline for wigs and any coding changes that may have to go with it, as well as the whole discussion on hirsutism. But otherwise, does anyone have any other things that they would like to pull out that they want further information or further discussion on?
Do we want to do a motion on this one before we go on to the next?
Motion that we accept this and then leave the wigs and hirsutism for more research and accept the other things.
All right. Do you have a second?
Second.
All right. Mark,
Agree.
Deb,
I agreed.
Larry,
Yep, agree.
Kat,
Agreed.
Leslie,
Yes.
Devin,
Yeah.
Linnea,
Yes.
and I just want to check to make sure no other members have arrived. See anybody in the meeting? Okay, looks like Mimi's not here yet. So, okay, the motion carries.
Great. All right, I'm just finishing my notes. Then the next topic coming back to you is actinic keratoses. We saw this at our April meeting. Just to remind you all, actinic keratoses, which are commonly known as AKs, are sun-induced precancerous lesions. They kind of look rough and scaly. The chance of it becoming a skin cancer, squamous cell or basal cell skin cancer, is quite low, much less than 1%. And some of these regress. However, if you are immunosuppressed, you have a history of skin cancer, or you have AKs in certain exposed areas like lip, nose, and ear, you're more likely to develop a squamous cell cancer than folks who don't have those risk factors. So we reviewed this last in 2006. At that point, it was thought that the chance of it turning into cancer was so low, and that there's a up to 25% regress, that there was no need to treat them, and that when they did become basal or squamous cell cancer, they could be treated at that point. So currently they are on line 620, and they currently pair on that very low line with excision and cryotherapy procedure codes. And photodynamic therapy and other treatment codes are not on those lines. So we looked at this at our April meeting, and everyone felt very comfortable with going forward with the staff recommendation at that time that said that covering cryotherapy would only be covered if a patient was immunocompromised, had a history of skin cancer, or had certain high-risk locations. However, since that meeting, our pharmacy and therapeutics colleagues have reached out to us, and they had questions about, they had questions specifically about use of phototherapy, which is where you give a certain drug to a patient and then you expose them to a certain wavelengths of light. It's a very expensive treatment. And then they also provided staff with with a rapid review that they had done of the evidence for various topical drugs for AK, which pretty much agreed with what we had talked about in April, that these are safe and effective treatments. So the rest of this is very similar to what you saw previously. And the main change since our April meeting is that we wanted to add photodynamic therapy to the AK guideline, and that the cryotherapy and photodynamic therapy also have the criteria that pharmacy thought was appropriate, that they either had insufficient response or a contraindication to the use of these topical medications. Because even with these high-risk patients, the pharmacy literature review found that the topical medications were more effective than cryotherapy or photodynamic therapy. So if you want to go down to the staff recommendation, Liz, all the way at the kind of at the bottom. So this is essentially what keep going. So this is what you saw at our April meeting and you approved with the new wording in there that's blue. That would be the change that I wanted to discuss today. So adding in photodynamic therapy, which again is this giving these expensive medications and then exposing to certain light, kind of that is considered sort of second line with cryotherapy. So putting those both in that bucket of only for high risk people. And then based on our pharmacy input, requiring topical medication use or indication that the patient wouldn't be a candidate for topical medications prior to covering the second line cryotherapy or photodynamic therapy.
if oh, sorry.
No, go ahead, Devin.
If photodynamic, maybe I misunderstood. If photodynamic therapy is substantially more expensive than cryotherapy, and they both are used to treat the same thing, do we really want to include both of them?
Meaning you should fail cryotherapy first before moving on to photodynamic therapy. Is that the?
I guess, yeah. I mean, I don't know enough about photodynamic therapy, but just from a pure kind of resource stewardship standpoint, if they're accomplishing the same thing and one is much more expensive than the other, they shouldn't be offered at the same time. So yeah, I guess Mark, that yeah, right. The way to address that would be to tier them in the way you suggest.
And is cryotherapy much more readily available
Oh yeah,
than
every
photodynamic?
primary care
Yeah.
office has.
Right. Okay. So it would make sense. It would make sense to cryotherapy first. And either if someone is not tolerant of that, or if there is some reason to not do it, then it would make sense to go. Yeah, it makes sense to be tiered, in my mind.
Do you all want me to look into the exact indications for photodynamic therapy and bring this back to you? Or do you?
I don't know
Yeah, I mean,
anything about. Yeah,
it
I've
doesn't
never.
seem like any of us know anything about it, but
Yeah.
It
Yeah.
didn't come up in our discussions with dermatology at all. It was more the pharmacy folks that were really concerned about adding coverage for AKs because of photodynamic therapy.
It's very underutilized if used at all, even in derm offices. I think almost everything is cryo. Everybody comes out with their thermos and they got it going on. So unless somebody has a specialty, because it takes certain amount of equipment and a lot of people don't invest in that.
yeah, I mean, which makes me always think cynically about shops that buy equipment and then try to get a lot of people sold on the equipment. But
I think it's fine to tier it. And I mean, because there is always the ability to have an exception, like somebody can't do cryo. It can be, accepted without stair stepping. So
The cryotherapy is more difficult if it covers more part of the body. That might be a factor for having access to the photodynamic therapy, potentially?
Yeah, and Deb, I was thinking that, and that's what I would expect on the appeal. It would say too many lesions to safely do cryotherapy. That's why it's indicated. So that's why I think it would be a one-off on the appeal. The provider would state that.
that's what 5FU is for, right?
No, 5FU is that's the topical medication that they use.
No, I
That
know.
is
I
the
mean,
standard.
right. No, I know what it is, but I'm just saying for the people that have
Too many.
several lesions, like, man, the argument that you don't want to do cryotherapy to a number of lesions, which I get, but I kind of thought that that's what 5FU is for. I mean, that's the way it works in our clinic. Like we usually start with cryotherapy for limited, just a small number of these lesions, and then 5FU if they have, more extensive disease. But
And I have no experience with this, so I'm out way over my skis on this one. Aside from tiering, makes it much easier on the insurance side, and we can always use the more expensive, fancier one if they fail the other one.
So we could say right now in our guideline it says, treatment with cryotherapy, blah blah blah. We could say treatment with photodynamic therapy is only medically necessary for patients who otherwise qualify for cryotherapy but either fail it or don't respond adequately to it, something like that.
Or there's some other circumstance that would make it more appropriate to have the photodynamic therapy.
Yeah, I would say almost if they failed 5FU and cryotherapy, then they, could be photodynamic therapy. I mean, lack of response, as you say, would be the same thing as failing it, I think, but
Yeah. That sounds good.
So photodynamic therapy is only medically necessary for patients who otherwise qualify for cryotherapy as above, but who fail to respond or have a contraindication to cryotherapy.
Would want to make it simpler and just say photodynamic therapy indicated if the patient fails other treatments.
No, because we have the topical.
Oh, you have to specify the topical and the
That's
cryotherapy.
the third line. Topical medication is covered for AKs.
Ah.
So wouldn't they have to fail both those things?
So what I have here, let me put this in the chat.
Yes, thank you, Ariel. And I'll paste it in.
How do I send to everyone?
Or email it to me or whatever is
I
easy.
will email it to you. That might be easier. One moment, everyone. We'll get there.
The goal is to make it third line, and so we'll have the information up on the screen in a moment.
It seems to me like it failed and or contraindicated. And contraindicated could include it's too vast a skin surface for cryotherapy. Does that kick the door in too far or leave it ajar just the amount we want?
So Liz will get the wording up in just a second. So the way it's written would be cryotherapy, you have to either try or have a contraindication to like 5FU or other topical medicine and some high risk condition. And then photodynamic therapy is only medically necessary for patients who otherwise qualify for cryotherapy as above, but who fail to respond to or have a contraindication to.
So are you making the standard treatment the cryotherapy or the 5FU or either?
So the 5FU is the standard.
Okay.
Or similar. There are other medications. It's not just all 5FU.
Right. Yeah. So that would be used first.
And then actually I missed a 2, Liz. So fail to respond should be 2. Sorry, in the blue wording down where you just added it.
What do you mean?
So who failed right there, fail to respond to or have a contraindication to.
But who fail to respond to.
Yeah.
Okay.
That's a pretty narrow door.
I think it's a pretty narrow door.
Yeah. Sorry to be nitpicky on this. Just the 5FU part of this, the group of patients for whom photodynamic therapy would be considered, I think, are the same group of patients for whom 5FU would be considered. In that it's this kind of more extensive field of is it, I'm also looking this up on open evidence.
Oh no, cryotherapy in the primary care office, that's any AK.
No, I know. I'm saying you would think of using 5FU if you had a bunch of them or they were over, a larger area, which is the same kind of set of patients in which photodynamic therapy would be considered. So I'm just making the point that in that sentence, we should, I think, also include 5FU as the thing that they should fail or be contraindicated to before considering photodynamic therapy.
Yeah,
So
that's
in order
fair.
in order to qualify for cryotherapy, you have to have insufficient response or contraindication to topical medications.
And
Oh, I didn't see that. Sorry. Okay. Oh, my bad. Okay,
maybe we
gotcha.
should
So
move that last paragraph.
it's
I think we
referring back
should.
to
I think
that.
we should move
Gotcha.
treatment to the top because that's our first line. And then the last sentence, Liz, should be moved to the first. Yeah,
Yeah,
exactly.
sorry.
And that's
I was
sort of
reading.
our layers. Try topical,
Good.
you fail topical and you have one of these high risk, then you get cryo, and you only get photodynamic therapy if cryo is not really a good option for you for some reason.
I understand this correctly. This is tiered. Topical, then cryo, then photodynamic therapy. Is that correct?
That's our intent.
Why is 5FU cheaper than cryotherapy?
Yeah, that's what I'm wondering.
It's more effective. But cryotherapy is ridiculously expensive when you look at it.
Is it okay? Yeah, it's a question. I mean, in the VA, I don't think it's more, because we just do it. But um,
I had a colleague who used to have a conversion. Everything was freezing equivalents. So like an IUD was two or three freezing equivalents.
Really? Okay.
Yeah.
All right. Well, yeah,
Okay.
I learned something. Well, then it makes sense. In my mind, cryotherapy is cheap, but that's because I don't get paid for it.
Okay.
Yeah, and I think some offices just do it on the side, but if you bill for it, it's hundreds of dollars. It's crazy.
Okay.
There's another consideration. The 5FU application is patient adherent dependent.
Yep.
So what if a patient is not adherent?
I mean, that would probably be true for the photodynamic therapy, I would guess too. But
Yeah.
um,
So because some people may just say, zap it off. I'm not comfortable, slathering something on my skin.
yeah, I mean, I think they would end up being considered a contraindication of topical medications or something. But
Okay. Right. I have a different question. So if we're done with this portion, I have a different question
Related to AKs or something else?
related to AKs.
Okay.
Page 64, so the following applies. Okay, the immunocompromised, prior history of basal or squamous cell carcinoma, and the AK is located on the lips, nose, ear, or eyelid. And my understanding is those are the three qualifications for a higher risk clinical situation. And so what I'm wondering is it seems that it gets pretty granular. And I'm wondering, instead of lips, nose, ear, or eyelid, if we could just say face.
No, a lot of them are on forehead. There's so many on the forehead. And cheeks and yeah.
Well, is the hmm, I'm just wondering if we have to be so granular. If we were to treat, if we're going to use the 5FU, which ultimately is cheaper than the cryotherapy, and we do that before we even consider the photodynamic therapy, is there any significant risk or harm or benefit to just using the whole face as the area that we want to treat? Or do we need to specify it to the lips, nose, ear, and eyelid?
I think the reason all this specificity is happening, Larry, is because of cryotherapy. It's not a huge cost per unit, but it adds up. And it's one of the ones that we've heard concerns about cost. So and just ask that you be mindful of that as you consider.
Yeah, and our dermatology experts have looked at this several times and they have not had any problems with it.
They actually said, I think that he believed that
They said we should, they
was
were the ones who said to put the topical medications in as first line.
because it's better at preventing cancer. I think
Yep.
yeah.
Yeah. So are folks comfortable with the guideline as modified?
I move that we accept the guideline as modified.
Second.
Let's take a vote. Jason.
All right. Mark,
I agree.
Deb,
Approve.
Larry,
About this one, but I am going to agree with it today.
okay, Kat,
Agree.
Leslie,
Yes.
Devin,
Yeah.
Linnea,
Agree.
and do we have Mimi yet? Look here. We do not see Mimi. Okay, so the motion carries.
Great. And Mimi's not here, so we will hold off further on our vulvar polyp discussion. And we'll move on to cysts, scars, granulomas, and keloids. This was pulled out at your request from the April meeting. We had talked about most of the dermatology things are going to be just evaluation and medical management. These were areas where you all felt that there might be some procedures that could be helpful. Either excisions, steroid injections, biopsies, etc. Specifically, you asked to look at skin cysts, scar conditions, foreign body granulomas, and hypertrophic skin conditions, which include keloids. So many of these are a variety of things. Cysts are collections of kind of pus or dead tissue, etc., that form kind of a ball that can get quite large. Scars and keloids, which are sort of really thick scars. Many of us have scars on our body. They're not a big deal. However, scars can, if they're over a joint, they can interfere with the joint function. Keloids, particularly because they're very thick and large, they also can cause pain or pulling or otherwise cause issues. In that case, steroid injections, laser treatments, cryotherapy, or surgical incision can all be helpful. Oh, and the other one is granulomas. These are the body's reaction to a foreign body. So if you have a small piece of something that has gotten under the skin or in the tissue somehow, you can get these sort of collections of inflammatory tissue. So all of these, I looked under all of these different types of things. I couldn't find any prior meeting minute discussions under any of these terms. When we talked about them in April, you all felt that we should consider treatment and asked me to reach out to the dermatology experts to get their opinion and their input. So these are on a variety of current lines below the funding line. I did an evidence review. I looked at management of keloids and hypertrophic scars. This is a review from 2024, which is based on expert opinion. They talk about liquid nitrogen, steroid injection, excision, and radiation as all things that can be helpful and can possibly prevent recurrence. Most private plans do cover some type of treatments for particularly keloids or scars that are causing medical issues, mainly pain and functional limitations. And then I reached out to Dr. Greeling and Dr. Doshi from dermatology. They actually recommended using the dermatology quality of life score that we use in our inflammatory skin disease guideline. They felt that although it was developed for inflammatory skin conditions, that there has been use with keloids and hypertrophic scars, which are a type of inflammation, and they can help determine whether there's severe functional impairment. And they reviewed the proposed guideline and codes and gave input. So what the current proposal is to add this whole group of codes for these hypertrophic scars and granulomas and cysts to a new group called keloid skin cyst hypertrophic scars and granulomas, and a new guideline, which will say that the following diagnoses only require treatment when there's evidence of significant functional impairment defined as is indicated by the dermatology life quality index. Those indexes are exactly the same as in the inflammatory skin disease guideline, and the cutoff scores of 11 or 13, depending if you're using the children or the adult version. And then there would be a series of different procedures that would be in this code grouping, including excisions, radiation, steroid injections, etc. Thoughts, input?
So I'm looking on page 71, and it says removal of skin tags. And I'm looking back on page 69. Is a skin tag ever considered a skin cyst or not? The reason why I ask is because if skin tags are not covered, I've seen a big skin tag that really got in the way of somebody's activities of daily living, and I removed it. So I'm just wondering, is there an exception for a skin tag that might be that might be big enough or in a location or both that causes a problem?
Yeah, currently removal of skin tags, which is CPT 11200, is proposed for excluded. And I believe we have the actual diagnosis code for skin tags proposed for evaluation and management, but I can double check that.
Because I wouldn't want to exclude someone who's got, quite frankly, a honking skin tag that really gets in the way. And every time, for instance, that they, dress or undress, they're at risk of pulling it and causing pain and, and bleeding.
Anyone else have?
I mean, I think that, these things can be dealt some with exceptions. I mean, it seems to me like things like skin tag, I have Kaiser insurance. I mean, I think it seems to me pretty standard that these things are not routinely covered.
Private insurance typically doesn't cover it unless it's like inflamed and you're concerned that it's not actually a benign skin tag. It's something else. And it's a diagnostic removal. But yeah, we always tell patients that it's not going to be covered. Sometimes we just do quick something in the office and don't tell anybody.
Yeah, they can always kind of do it under the counter there. But I'm not I think it's kind of I wish we could cover everything. I think
No, I'm not suggesting we cover everything, but I'm just saying this is very specifically if there is something, a skin tag, and it is a skin tag that actually really does interfere with someone's ability to dress, undress without causing pain and bleeding. I'm just wondering, is it what is the best way to handle that? Would it be through exception or just plain, as you suggest, to do it under the table?
From our standpoint, it would be best through an exception if there is a true exceptional circumstances. I would caution using the term activities of daily living because that has a very specific diagnosis. Community or the lay press may have a different interpretation of ADLs versus what we have as ADLs. And that's why we generally would use that functional impairment or some sort of criteria.
Okay, if calling it functional impairment is okay with me.
I just wanted to link this to the discussion that we'll have when Mimi gets here. Oftentimes, the vulvar polyps are often called skin tags. That's different than a cervical polyp, which is in a different location. So these are relevant conversations. I just wanted to make sure we.
Yes, thank you. Yeah, thank you.
Whoop, Heidi, you're sort of really breaking up. And I did also want to call out one additional thing, which was lipomas that were called out. I actually talked to a surgeon, and that became a whole different topic, and that's going to be on the agenda next week at VBS and HERC, in case anybody was missing that particular topic. Any other questions or discussion about granulomas and scars and keloids? Oh my.
So, Mark, has anyone ever asked for an exception for a skin tag removal, like in the case of some functional impairment?
I've never seen a skin tag. Scars, definitely. But I think all skin tags are probably removed in the office, just under the snippet type of thing.
Hmm.
But no. Since there's some dead time on those scars, Ariel, is laser therapy on there? Because we simply get it was a fair amount of requests for the laser treatment for.
Yeah, it's the 17000 to 17111. I think the laser was it was in that that. Let me see if I can pull those.
Oh, that's on page 72.
Yeah, I'm just gonna. I lumped a bunch of codes together. I'm gonna see if I can. Yeah, so laser surgery is lumped in all of the ICD-10 or ICPT codes with electrosurgery, cryosurgery, chemosurgery, and surgical curettage. They're all kind of together.
Okay, thanks.
So do we need a motion to go through or this is scars, granulomas, and keloid statement below?
Yes.
Okay. Are people ready for that? It sound like dead time. Dead time to me means let's move this. So anybody wanting to move the section, and you could bring it up so we can see it.
I move to do this.
A second?
The staff recommendation as written.
Yeah.
Anybody second?
I'll second.
Thanks, Deb. Let's go for the vote.
All right, Mark,
Agree.
Deb,
Agree.
Larry.
I mostly agree, so I agree.
Okay, yeah,
Agree.
Devin,
Yes.
Leslie,
Yes.
Linnea.
Agree.
All right, motion carries. Looks like Mimi is not here, so I guess we can bring the polyps topic back
Yeah.
to the September meeting.
Yeah, so just as for next steps for you all, staff will work on bringing the topics that you have approved to make a handout for the meeting for HERC next week. We have a lot on the HERC agenda next week, so they may actually not get to it, in which case it will be discussed at the August meeting. So keep an eye, just if you're interested, you're always welcome to come to those meetings. They're virtual and in person if you want to just hear what happens. And then we have a list of topics that will be returning to you all for further discussion in September.
Okay, and then the next meeting is not September 4th, it is September 11th. We had to reschedule that, and apparently our agenda did not get updated correctly, so apologize for that. So September 11th. We'll just plan on it being online. This group doesn't seem to want to drive to Wilsonville. We'll look forward to seeing you all and have a wonderful summer. If there's nothing else, Linnea.
No, best to everybody. Take care.
Thank you all.
Very good. Okay.
everyone.
Thank you much.